is technology-driven lifestyle intervention, dietary modifications, and psychological care are more important for Asian subset, and we will be following the same case scenario. Thank you.
So, good morning, everyone. Am I audible? Yes. So, first of all, I would like to thank Dr. Kamal Sharma for giving me the opportunity to address this August gathering and to pitch me against none other than Dr. Romit Bhattacharya. So, I stand here for technology-driven lifestyle intervention, dietary modifications, psychological support to all, an effective strategy to tackle CVD in genetically susceptible Asian subset. I would like to start with this quote by Dr. Tedros. Harnessing the power of digital technology is essential for achieving universal health coverage. Ultimately, digital technologies are not end in themselves. They are vital tools to promote health, keep the world safe, and serve the vulnerable. This patient who has come to me is a 39-year-old hypertensive, new onset diabetic, and he has lipid disorder, and I have optimized him on medical therapy. Now the question is what I am going to do next. The core components of cardiac rehabilitation includes blood pressure management, lipid management, diabetes management, then giving them advice regarding tobacco cessation, psychosocial management, and physical activity counseling. And we definitely know that healthy lifestyle or healthy life behavior definitely decreases the risk of developing CVD and has associated benefit of giving a good quality of life. But what are the fundamental challenges that we face in delivering the long-term optimal care in such patients? The challenges include their varying risk factors, differing lifestyle food habits, socio-economic conditions, aging population, early onset disease, constraints in healthcare workforce, lack of follow-up, and service delivery. And what are the potential solutions in the present scenario? Patient self-care empowerment are increasingly becoming important. We have to enhance the usage of digital healthcare technologies, precision in diagnosis as has been pointed out by Dr. Romit Bhattacharya, and providing optimal and technology-driven lifestyle changes to all. How can we create the efficiency in CAD care pathway? We can better integrate heterogeneous medical devices, use user-friendly technological interfaces, increased automation of manual processes, improve standardization of the entire process, increase utilization of health information exchange, and seamless portability of information. Now the question is, precision therapy or technology-driven lifestyle modification for all? We all know that atherosclerosis is a disease which has got a very strong genetic predisposition but is modifiable by lifestyle. And genetics and environment, they play role together to further enhance the risk. I would like to bring to your notice this slide which shows that the totality of exposure from conception throughout the life course leads to multiple physiological changes in an individual, and these damages which play a role in health and chronic diseases. Genetic risk stratification definitely is superior to conventional risk stratification for primary prevention of coronary artery disease, but clinical trials have shown that 40 to 50% of it can be reduced by lifestyle, physical activity, and proper usage of drugs. This study, which has been published by Dr. Romit Bhattacharya, and as he has mentioned, that polygenic risk score increases the accuracy of cardiovascular risk prediction. I agree with that. And personalized intervention is definitely useful because we can risk stratify into high, intermediate, and high risk group, and then we can give them individualized treatment. I would bring to your notice Masala study, and the findings underscore the importance of maintaining ideal cardiovascular health regardless of ethnicity. And it has shown that there is a strong association with, between Life Simple 7 matrix and coronary artery calcium incidence and progression. And irrespective of any ethnicity, we have to look into the lifestyle and correct that. Again, this study published in NEGM, it has shown that favorable lifestyle is associated with 50% lower risk, relative risk correction of coronary artery disease. So, being in India, being in a developing country, do we invest our resources in genetic analysis or motivate usage of technology-driven intervention for all? See, as we all know that technology is one of the biggest invention of humankind. And as the mobile usage and other things are increasing, it has made us sedentary and it has increased the lifestyle diseases. This is a bane, but the thing is we can convert into a boon because in India, right from the topmost person to the rickshaw puller, everybody has got a smartphone. And if we integrate this, this possibility and if we integrate healthcare apps in all of them, we can definitely percolate this information to one and all. And definitely we can convert this bane into a boon. Right from the beginning or now? Now. Thank God. Yeah, so I'll continue with that. So the thing is, what are the potentials of digital healthcare intervention for CVD? It empowers patient and the care provider. It reduces healthcare cost. If we go into the genetics, definitely the risk, the cost escalation would be there, especially in a developing country like India. It promotes universal health service coverages, improves patient experience of care, and improves long-term patient outcome. Thank you so much. Yeah, and as we see that in last decade or so, there is a definitely increase in digital health market. It is growing by almost 30% per year. This study, which is published in JACC, shows the ecosystem which works between the patient and the caregiver who are connected by the app. The data goes to the remote processing center. The analysis is done which goes to the doctor as well as the information goes to the patient. And not just that, these informations can be collected and can be utilized for research facility as well in future. So this slide is very important, not just for this patient. What I want to highlight that if we pool this data, definitely by AI, we can get new set of data, hidden patterns, and learn better action in future. And it has the potential to assist in prevention, detection, and intervention in coronary artery disease. These are the various apps which are available, not just healthcare apps, medical apps, mental health apps, fitness apps, telepharmacy apps, and whatnot. And these are the various parameters, just for an example, which we can get from just a watch. One such app is Lifey Digital Therapeutic Ecosystem, where the Lifey patient has an app. Again, the caregiver has one app. It is Bluetooth enabled, and the information is obtained by the experienced team of cardiac rehabilitation specialists. And this app is also connected to the doctor, and we get the desired outcomes. Lifey device awareness and lifestyle changes definitely integrates and gives a multidisciplinary team to the patient, and it is customized. The dashboard is customized according to the patient, and emergency services are also provided. I request I should get few minutes because of the lack of the coordination. These are the various studies, and I would like to quote from one of the study. Digital therapeutics build a lucrative bridge to help cardiovascular patient crossover into improved quality of life in place of traditional face-to-face CR regimes. And this again study shows that there is a definite advantage over traditional interventions, and by automatic tracking of real-time data and two-way communication outside the traditional appointment-based healthcare model is definitely effective in delivering a better cardiac care. Digital twin, which is a one-year randomized control trial, again showed that by using a virtual platform and by creating a digital twin, we can get better blood pressure control, antihypertensive medical reduction, and remission of hypertension as well. These are the various comparable devices which has different capabilities, right from smartwatch, fitness tracker, chest strap tracker, smart clothing, blood pressure monitoring. And studies have shown that remote monitoring and using these technologies have reduced hospital readmission, improved fitness, improved diet, and also helps in better blood pressure and diabetes control. Anything we use in life, anything we want to do in life, always we do a SWOT analysis, whether we want to go ahead with that or not. So if we do the SWOT analysis of technology-driven lifestyle intervention, the strengths are, it enhances the quality of care delivery for all the patients. It improves patient centricity. It enables distributed and hybrid care. Patient can come to the clinic, even in remote we can take care of them. It develops innovative healthcare ecosystem. It enhances patient satisfaction because he can see what he is doing, how many steps he is walking
Recording
per
in
day.
progress.
And it improves patient data record and reassessment. The weaknesses include lack of national guidelines, lack of digital literacy, lack of perceived effectiveness of DHI, lack of common standards, various apps are there, limited infrastructure, loss of privacy of data, as well as, last but not the least, added burden on medical staff and data for assessment of those information. The opportunities include better availability of tool, lucid data analysis, and better patient compliance. The threats include data-related threats and lack of follow-up and effect on doctor-patient one-to-one relationship. So I would like to conclude by saying South Asian predisposition to CAD due to high genetic risk, erratic lifestyle, and unfavorable conditions make early introduction of technology-driven interventions to all not a possibility, but an inevitability. Thank you for your patient listening.
So everything we listened about technology and how these ever-increasing technological access and AI and deep learning, machine learning models can help in future. But may I ask Dr. Shilpi how, Dr. It's not available, how this technology or whatever you said here can help a patient, index patient in the case he's diabetic hypertensive and is under 40 and is rosuvastatin 20 and LDL is way above. It's a kind of an atherogenic diabetic dyslipidemia. How, Dr. Bhattacharya, or you, this technology and this awareness about that we being in a very high risk race can help? How can he adopt this and what amendments in lifestyle can he, or we can help him choose right drugs in an algorithmic way so that he reaches to his all goes lipids, blood pressure and cholesterol?
Thank you for this question. See, this patient has come to me. We already know that he has diabetes, hypertension, and dyslipidemia. The thing is, I would give him the proper counseling as I started in my first slide, that I would counsel him that these risk factors are there. Maybe you have a family history as well. So these risk factors will definitely play a role. Although right now you don't have a myocardial infarction, but in future you can have. So what you need to do is you should have your app on the mobile as well as on the phone, which can help you in getting how much steps you are walking per day. So at least I will tell him at least 8,000 steps at least you complete per day. 10,000 is a good distance. And then you can check your diabetes also by using the sensors. And periodic follow-up, if you can come fine, otherwise these data will come to me and then I will analyze, or my team will analyze and then will guide you. So the patient will feel confident that yes, the doctor is in touch with me and I feel confident that he is seeing what he is getting and he will be more motivated to do because he will get the right response.
Are they exposed to? I know in many parts of India that's a huge issue. And so those are not things that we are necessarily able to change by encouraging people to, use an app differently or that kind of thing. By contrast, I would say that therapies that can be disseminated as a pill, so that the therapy is uniform, or as an injection, the therapy is uniform. You can adjust them and give them once at a time. They are much easier to deploy in a global context across all different contexts and with relatively less effort on behalf of the patient. So in that regard, I think that genetically informed therapies are extraordinarily potent in that you know that you're particularly inhibiting or augmenting a particular biological process, and that does have a lot of merit. Uh, in regards to this particular discussion, we're really focusing on lifestyle and behavior. And the question of whether genetics can influence lifestyle behavior, I think really the biggest thing is, can it influence people to change their behavior? And I think when we try to tell everybody everywhere all at once that they should be eating better and exercising, oftentimes that message lands on deaf ears because people only have a certain amount of bandwidth in their day to be able to put effort behind their health behaviors. However, when you tell them that you specifically are at higher risk and you're able to share that information about them in particular, or even more so about their children, to say that your children are at higher risk, it would be really helpful for them if they made these particular changes, if they ate in this particular way, if they exercised in this way, if they slept in this way, if they were able to rest and recover in this way. Then people feel that that advice is targeted towards them. And this is the holy grail of personalized medicine. We haven't yet been able to realize, and today is not a reality yet. But I very much hope that that will be a reality in the future, and we're working very hard towards that reality. So thank you very much. Great, thank you.
I think both genetic counseling as well as health driven by this modern technologies, both are important in their own ways. And I personally use this life application in my patients and finding good results. And we as a cardiologist not only treat our patients, but we have to do primary prevention of their relatives as well. So I think that way.
See, the thing is, even if we do the genetic analysis, especially in a country like India, we are adding to the cost. That is number one. On top of it, even if we say that you are a low-risk patient, high risk, okay, we will tell him, okay, you are high risk, okay, you be very careful. Even if he is a low risk, we cannot say that, okay, go have rasgulla every day. So that is the point. So it is better to give him an app and then take him ahead in the futures to come. Thank you.
Wouldn't Dr. P, can we consider, given the incidence which is obnoxiously increasing and percolating down to lower decades, 20s and 30s, and we are witnessing SCDs like anything, we consider our Indian race laden with risk factor, constellation of cardiovascular risk factor as a high risk. Forget about genetics. We doom it. We consider it too that we are high risk. And patient like this, Dr. Kamal drafted, diabetic hypertensive, and on 20, which is moderate to high dose, and yet not dropping. I think we have to go on guns blazing without putting any additional thing because it's an extremely high risk of major adverse cardiovascular and cerebrovascular events. So rather than technology and all, of course, technology does help in assuring lifestyle adherences and persistences. We think that he is on GDMT for all structural and functional comorbidities. And one more of the questions. Sani is here. LDL is way above 120 over on rosuvastatin 20. Can AI help diagnose familial hypertriglyceridemia, which is prevalent in a country which we don't see? We don't do cascade screening for that. So is this a possibility in this index case of familial hypercholesterolemia, heterozygous, in spite of being on 20? Before ushering into incremental high-intensity lipid lowering over and above high-intensity statin. Because it's AI-based symposia, so can AI help in that, in risk triaging?
Yes, definitely. The more we go into the details, more information we are going to get. More information we are going to get, then we can implement that in the future course of action. Definitely that can be done.
Comments from the moderators, Dr. Komal, Dr. Kinneri.
So I have like a couple of questions, but one prime central question would be, we have been knowing this conventional factors, conventional risk factors, they explain majority of the risk. How much risk are we expecting genetic factor to be explaining? Like 80% of the risk is because of diet, dyslipidemia, sedentary lifestyle and all those things. Are we expecting genetic factor to be explaining 20% of the risk, or is it just a nominal thing?
I think the slide is there. I've displayed that slide.
Pardon?
I've displayed that slide, what percentage was our question. So Yeah, for CAD maybe not, that's a valid point, but dyslipidemia, you can do a sequencing and get 60-80% yield. Marfan's 90 to 95%. Cardiomyopathies maybe 20-30%. Hypertrophic cardiomyopathies maybe more. But even when HCM, where a lot of genetic stuff is thought to be, it's not more than 50%, so point is very valid.
Yeah, thank you. That's it.
One of the slides in Dr. Ronit was very good. If you have genetic risk, and if you adhere to lifestyle, you respond very well to the lifestyle changes.
Exactly.
I just saw the slide. And if you have genetic risk, and if you don't adhere to the lifestyle amendments, you have the, it's a harbinger of a very ominous prognosis. A very good slide, so it
So-
correlates with this thing.
Yeah, so
But in spite
that's
of all this, we still don't predict STDs well in India. All these are, of course, for channelopathies and in this video, we have predictions. But for CAD-related events, it's still a big elusive enigma.
true. And that's where I guess role of
Because it is
epigenetics comes into picture. Role of epigenetics comes into picture. And I guess we don't have majority of the Indian representative data in that
That's
PRS
been
scoring
brought out by
system.
Dr. Romit that India is South Asia is underrepresented, definitely.
Thank you.
Good session, good discussion. Any question from audience? I think session is closed for that.
Hello.
So we have a lunch break for half an hour. Thank you so much all chairpersons and Dr. Shilpi. Kindly collect the memento from